So I'm going to start this session with a discussion about the potential merits of implementing a team-based approach to the management of cardiogenic shock. And for full disclosure, I am not at Equipose here. I feel very strongly that a team-based approach is the way to go. And I hope over the next 15 minutes to convince you that this is the right thing to do for your patients and your hospital systems. What I'd like to do is start out with a very, very brief discussion about historical outcomes in cardiogenic shock, because we're going to use that data as a comparator later on in the discussion when we talk about the potential value of implementing a team-based approach. I'm going to spend just a few minutes talking about the rationale or the arguments that have been put forward by experts supporting a team-based approach to the management of cardiogenic shock. We're going to spend some time talking in a really granular level about shock team components, and I will tell you how the shock team at Baylor St. Luke's is organized, how it's activated, who's involved, and what their roles are. And then I'm going to wind up to discussing some emerging data that has been coming out over the past several years that I think really supports the use of a team-based approach to the management of cardiogenic shock. So let's get moving. Cardiogenic shock outcomes. Cardiogenic shock, as most of you know, getting randomized data is very difficult. We have 3 big, robust trials from which to draw on, and all this data is cardiogenic shock complicating an acute myocardial infarction. We really don't know if we can generally apply this to the cardiogenic population, but this is the best that we have. So the shock trial, I think many people in the audience are already familiar with this. It's patients that presented with an acute myocardial infarction complicated by shock. Patients were randomized to revascularization versus medical therapy. And a couple of take-home points. First of all, patients that underwent mechanical revascularization had a survival benefit, but in excellent hands, the survival was only 53% at 30 days. We move on, so almost more than a decade later, the IABP Shock 2 trial. This trial randomized patients that presented again with cardiogenic shock, complicating an acute infarct, and they were randomized to routine use of intra-aortic balloon counterpulsation to standard therapy, and there was no advantage to routine balloon pump use. The survival was 60%, and so there was some general enthusiasm or optimism because we thought, well, maybe we've learned something over the past 13 years and we're actually doing a better job taking care of these patients overall. Then shortly thereafter, we get the culprit shock trial, and this looked at patients that, again, acute myocardial infarction, cardiogenic shock, multivessel disease, randomized to multivessel PCI versus culprit lesion-only PCI. And the patients that underwent culprit lesion-only PCI had a survival advantage, but soberingly, the overall survival was only 53%, and these were very, very tightly controlled patients. So over about a 17, 18-year period, the survival really had remained fairly flat, right? So it really gave a lot of people pause. So from 1999 to 2017, the mortality for cardiogenic shock somewhere between 40 and 47%. So wide implementation of mechanical circulatory, the intra-aortic balloon pump counterpulsation, tandem heart, widely implemented, but no proven survival. Lots of discussions. So maybe it's not the care, how we're providing that care. And I think it's important to remember that the standard cardiac emergency care paradigm was really developed for the treatment of acute myocardial infarction and does a good job for that, right? But let's think for a minute about how that works. So we have an emergency department physician that sees the patient, triages the patient, initiates the care, and then activates a STEMI team. Patient is then taken by a different group of people to the cardiac catheterization lab, where hopefully they undergo a revascularization procedure. And then the patient is moved out to a cardiac intensive care unit. And a lot of times, that's yet another group of physicians that are taking care of that patient. And, these doctors do communicate with each other, but there's no formal multidisciplinary discussions. And there really is a lot of siloing. And I think that for patients in cardiogenic shock that are so complex, patients that are on mechanical ventilators and mechanical support devices, and a lot of them are on CRT and vasopressors and inotropes, and they have infections and nutritional issues, having siloed care is not optimal. And it really requires kind of a Superman to do these sorts of things. I don't know of any individual physician that has the background, experience, or bandwidth to do all these things, to triage, perform the PCI, do the large bore access, put an antegrade sheath in, insert the temporary MCS device, manage the device, put in a surgical device, manage a ventilator, manage hemodynamics, perform and interpret invasive and non-invasive imaging, talk about escalation of care, and determine when care is futile. That's a lot to put on one person. Lots of discussions nationally and internationally about how we might be able to improve this, and it was recognized that in other complex, time-sensitive, critical illnesses that a team approach has led to better outcomes. So implementation of code teams, rapid response teams, stroke teams, trauma teams, all these are time-sensitive and complex, and implementation of a team-based approach to those critical illnesses resulted in better outcomes. So that was one of the rationales. We have become accustomed in cardiology over the past several years to the use of multidisciplinary heart teams, especially in structural heart disease. More and more for complicated cardiac arrhythmias, we've used it forever in transplant and durable MCS. More and more for complex coronary revascularization. So a team-based approach is really becoming the standard of care for many complex cardiovascular conditions. We began to see a plethora of opinion papers in the major cardiac journals really expounding upon the rationale of a shock team approach. And these are 4 very, very good articles. They do this much more eloquently than I will, but they really put forward the same sorts of arguments that I am currently. And if you're interested, I think that these make for great reading. But ultimately, what they did is they formulated the goals of a cardiogenic shock team. And that is to facilitate early recognition of cardiogenic shock and to expedite multidisciplinary discussions, focusing on the emphasis of the need for timely MCS device selection to make sure that the correct devices went in, appropriate escalation of care, and also focusing on streamlining and standardizing this care. The American Heart Association put out a scientific statement on the management of cardiogenic shock, and it really helped outline who at least they felt should be involved in a shock team. And I will run through that with you. This is from the AHA scientific statement. And they recommend that on-site medical consultants, cardiologists for implantation of MCS, imaging specialists, advanced heart failure specialists, electrophysiologists, palliative care, neurology, an intensivist, either cardiology or ICU, cardiac surgeons, nephrologists, palliative care physicians, and then a whole host of ancillary consultants, including a dedicated pharmacist, social work, physical therapist, respiratory therapist, occupational therapy, and dietitian. So really emphasizing the fact that it takes a village to take care of these patients. This is a prototypical shock team workflow. Anytime that cardiogenic shock is suspected, you want to have a mechanism to activate your shock team, and this should be something that's readily available and easily done. Who is on the shock team? Well, you definitely want a critical care intensivist, ideally a heart failure specialist. You want an interventional cardiology or a cardiac surgeon or both, but we need someone to implant these devices. In our institution, we really lean on our interventional cardiologist. We don't have a cardiac surgeon as part of this process. And then someone to take care of the devices, so a circulatory support team. So what do? Well, they want to evaluate these patients rapidly. So rapid multidisciplinary evaluation, sort out what's going on with these patients, rapid invasive hemodynamic evaluation, and then additional diagnostic, always going to include an echocardiogram and possible some other diagnostic studies so that the team can come up with a rapid therapeutic intervention selection. So how do we do that at Baylor St. Luke's Medical Center? Well, anytime anyone in the hospital system suspects cardiogenic shock, they can activate the system. We have put together some guidelines, some recommendations. So certainly patients that are having hemodynamically significant arrhythmia, so VT storm, patients that have inadequate perfusion, we've given some guidelines, so cardiac index less than 2, wedge greater than 15, CVP greater than 6, hypotension, tachycardia, worsening renal function, worsening liver function, oliguria, lactic acid that's not trending down. But these are just recommendations. Anytime someone suspects cardiogenic shock, all they have to do, pick up the phone in-house and ask the page operator to page the shock team, and it puts this mechanism in place. So what happens? Well, we are very fortunate. We do have house staff, and I do have a heart failure fellow that is either in-house, or I have a cardiology fellow group that is moonlighting in that position. So we get them involved immediately. They go immediately to the bedside and do an initial screen. They will confirm that it's cardiogenic shock. They will usually perform, make sure that we're not dealing with vasodilatory or some other sort of problem. And then they will notify the advanced heart failure cardiologist. Once the advanced heart failure cardiologist discusses this with the fellow, the advanced heart failure cardiologist, the interventional cardiologist, and our intensivist either meet at the bedside or more often have a conference call and discuss the patient and decide on a therapeutic plan, a device strategy, and an exit strategy. And we try to plan all that stuff up front. Once we decide what's going to happen, then the appropriate support personnel will be evaluated. If we have time to move, the patient team will be mobilized. If we are going to emergently implant ECMO at bedside, then our circulatory support team is mobilized and they bring the equipment to the patient's room. After the MCS device is placed, then the advanced heart failure team assumes care of all these patients. This is just the algorithm that we use to help decide which device. I'm not going to go through this. This is really just put this up there just to sort of illustrate the complexity of the decision making. I think it underscores the need to have a multidisciplinary team, people from various backgrounds weighing in to go through this algorithm and decide the right course of action for each of these critically ill patients. So let's move on to outcomes and what we're starting to learn. I showed you this at the beginning of the talk. So from 1999 to 2017, survival was flat, right? So mortality was somewhere between 40 and 47%, no matter what we did. Very interestingly, in 2019, we started to get data from the National Cardiogenic Shock Initiative, and they were reporting a mortality of 28%. And I tell you, when I first saw this data, I was a little skeptical. I was enthusiastic, but skeptical. And this was a one report. Yeah, it's multidisciplinary, but it's one so out of line with everything that we had seen in the past. I admit that I was skeptical, but then we started to get more and more reports. So we got the ANOVA data. So ANOVA reported their survival before and after implementation of a shock team and clearly showed improved survival. Same at the University of Utah and same at the University of Ottawa. So we're starting to get this real pool of data that's really suggesting that implementation of shock teams is really improving our outcomes. So this came out 2 years ago, and I thought that this was a very, very interesting publication and maybe shine some light onto why we may be really seeing improved outcomes with implementation of cardiogenic shock teams. So this is data from the Critical Care Cardiology Trials Network. This is a network of academic hospitals within North America. There were 24 centers involved. 10 of the centers had previously implemented a shock team approach, and the other 14 had not. And what they decided to do was just look at their data and see if there was any difference in decision-making and outcomes in the groups that had implemented a shock team versus the groups that had not. And so I'm going to show you some of that data. One thing that came out of it was that the initial MCS device selection was really quite different depending on whether the selection was done via a shock team or not. So the hospitals that hadn't implemented a shock team tend to rely more on things like balloon pumps, and the groups that had implemented a shock team were relying more on what we would call more advanced MCS, so things like Impella and Tandem Heart. Now, I showed you before that these advanced therapies have not been proven to improve outcomes, but the fact that the decision-making was different was quite interesting. How does that affect other things? Well, this is data from the same publication, and importantly, in the groups that have implemented a shock team, the use of PA catheters to guide management in cardiogenic shock was much higher. And we're already dealing with a group of very, very high quality cardiac intensive care groups that had implemented a shock team. PA catheter use was still higher. And we know that in cardiogenic shock, not heart failure in general, but in cardiogenic shock, the use of PA catheters are associated with improved outcomes. We talked a bit about MCS. Interestingly, I didn't point out before that the overall MCS was actually lower in the groups that had a shock team, but the shock team groups were using more advanced forms of MCS. Again, just showing that the decision making in these programs tends to be a little bit different when it's protocolized and you have a multidisciplinary group making the decisions. Most importantly, improved mortality, improved survival in the hospitals that had implemented a shock team versus the ones that had not. And I think it's an emerging data set, but it's very, very important, and again, supports the use of a team-based approach to the management of cardiogenic shock. So I'm going to just offer some summary now. Despite advances in care, cardiogenic shock mortality has historically remained high. The management is complex, time sensitive, and I think ideally multidisciplinary. There's been a lot of expert consensus documents that have recommended a multidisciplinary team-based approach, and we have preliminary data to suggest that a team-based approach improves standardization of care and outcomes, more likely to use advanced temporary MCS devices, and importantly, have a lower risk-adjusted cardiogenic shock mortality. So I'm going to wind up there and toss it over to Joe.
As was stated earlier, it's really an honor to be able to provide some commentary on heart failure programs in the context of this symposium. And it's been wonderful as a sidebar to connect with my old friend Doug Ensley, who, despite having lost track of each other for years, whenever we started talking, it was like we didn't skip a beat. And so it's been a wonderful part of this last several months is reconnecting with Dr. Ensley. I was asked to make a few comments about building a comprehensive heart failure program and sort of the rationale and how one might go about that and what components one might include. So I'll start with the why. And the why is that we have an epidemic of heart failure in the United States, and there are a variety of different facts on this slide, but many of them quite relevant to our day-to-day practice of medicine. 1 in 8 deaths in the United States has heart failure as one of the diagnoses. We've got over 415,000 deaths that will list heart failure as a diagnosis. There's 6.7 million people in America who are living with heart failure. And you can kind of read through all of these, but I also want to highlight this issue on the right side of the slide, that it's an intensely expensive condition for U.S. healthcare. We're spending about $70 billion annually managing this patient population. And you can see in that pie chart that about 3/4 of that is being spent on the direct medical care for this patient population. So high incidence, high prevalence, it's actually increasing, very expensive, and associated with an awful lot of morbidity. And the burden on underrepresented members of our society is disproportionate. And I think that's an important concept that we should continue to remember as we're continuing to concentrate our efforts on healthcare equity. This is probably not a big surprise to any of us, because a paper that was published in Circulation, Heart Failure, in 2012 predicted this progressive increase in the number of Americans who have heart failure. And you can see on the left side of the slide that regardless of one's ethnicity, on the right side of the slide, regardless of one's gender, it was projected in 2012 that over the ensuing 20 years, the incidence of heart failure was going to continue increasing. And then a more sobering paper came out last year that was published in the Journal of the American College of Cardiology, projecting what we're likely to see up until the year 2060. And it was based on the risk factors for cardiovascular disease. So you can see in this table that over the next 40 years, it's anticipated that the incidence of diabetes is going to increase by 40%, hypertension by 27%, hyperlipidemia by 27%, etc. And the impact of that on the right side of this slide is shown that we're going to project that in the next 40 years, there's going to be a 33% increase to 13 million Americans who have a diagnosis of heart failure. So Why build a comprehensive heart failure program? It is for this reason. It is the right thing to do. And I think that there's going to be incredible pressure put on healthcare to come up with new and innovative solutions to try to manage this problem. And hopefully what we'll get to is a point in our conversations where we're thinking about how to prevent the development of heart disease based on this metabolic syndrome profile that's highlighted in this slide. The other issue that's very sort of relevant to this discussion, and is particularly in the minds of our administrative colleagues in the hospital, is our initiatives that are going on to try to bend the curve on hospital readmissions, which is an important driver of cost for the overall patient population. And most of you will recognize that that CMS put into place the Hospital Readmission Reduction Program, focused on several disease processes and putting the responsibility back on the hospital, not just for the period of time patients were in the hospital, that they were extending that hospital's responsibility to this vulnerable period when after patients had been discharged following an admission for heart failure, and tagged to it a financial penalty if the readmission rates were high. And a very interesting observation was made. This program was implemented in 2012. You can see that in both of these slides. And you can see in panel A on the top that when the program was implemented, there was a reduction over the next couple of years in readmission rates, in 30-day readmission rates. But of great concern, and not anticipated by those who developed this program in the federal government, there was an uptick in patient mortality. Now, you can interpret that in whatever way you want, but I think that there are some perverse incentives potentially that we need to be watching for, and this kind of data needs to be analyzed and thoughtfully collected and reported, so that we're not seeing unintended consequences of some of these well-intended initiatives to reduce the cost of chronic illnesses, heart failure being one of them. So why build a comprehensive program? So I've just put a number of thoughts over on the left side of this slide, but it certainly, as we've talked about already, a very vulnerable population with high morbidity, high mortality. It's increased in underrepresented populations in the United States. It's a complicated disease. And in fact, it's sufficiently complicated that the American Board of Internal Medicine has a subspecialty examination in the field of advanced heart failure. As Dr. Civitello pointed out, there's pretty compelling evidence that multidisciplinary care improves outcomes, and I'll show you a little bit more about that in an upcoming slide. I think that for a hospital thinking about getting back into this clinical care delivery paradigm, there's an opportunity to maintain I put a technology gradient, but a gradient that's driven by clinical trials, where you have the newest, most important, interesting, innovative therapies that may not be available to our patients in other places. I think it's important to recognize that while we're focusing on heart failure, it's obviously the entry point for many other cardiovascular and non-cardiovascular services. As I've mentioned, hospitals and soon physicians will be going at risk for the cost of this patient population. I'll show you a little bit of data to suggest that if the program is put together well, it can be financially advantageous through the generation of revenue, but also through cost avoidance. And I think that's another component of this that we need to be watching. And finally, and maybe most importantly, it just seems like the right thing to do to provide a different level of care for this very challenged and vulnerable population. So this is a schematized a representation of what a comprehensive heart failure program would look like. And Dr. Civitello showed something very similar to this in the context of describing cardiogenic shock. But the idea is that you surround an individual patient with a variety of different subspecialists that are looking at problems from different perspectives and using their expertise, bringing their expertise to manage this patient in a better and more effective way. And while you look at this and you think, this seems like a pretty idealized schematic, it would be great if we could actually make all of this work, what I would challenge each of us to do is to pause for just a moment and put yourself in the patient's position. And isn't this what we should expect from medicine in 2023? That we're bringing the smartest people with the most expertise around a sick individual to provide that perspective to cure or to help them get through an illness. And I mentioned a little bit ago about the complexity of heart failure therapy. And I don't mean this to be sort of a mind-boggling exercise, but these are some of the combinations of standard medical therapies and some of the newer therapies that are available for heart failure patients. And what I'd like to impress upon you is that if you compare the treatment of these patients with pharmacotherapy to placebo, which is shown at the very bottom of this slide, as you begin to add the most standard heart failure therapies and the most standard guideline-directed medical therapy is shown at the top of this slide, we're seeing all-cause mortality reductions on this quadruple guideline-directed medical therapy, reductions of 60% in all-cause mortality. So it is a complicated area for cardiologists. I think many cardiologists don't have the bandwidth to really focus on getting patients on this, and that's actually supported by national registry data that shows that we're not good as a country at getting patients on this quadruple therapy for heart failure. And I think concentrating these patients in centers of excellence that have the expertise to implement this kind of approach will be beneficial to patient populations. And not in any way to forget that heart failure almost never is an isolated illness. It almost always has important comorbidities. I mentioned diabetes and hyperlipidemia a minute ago, but it oftentimes is associated with some amount of kidney insufficiency, with frailty, with some of the social drivers of health, which we're not going to spend a lot of time talking about, but we need to begin focusing on if we ever hope to really bend the curve on heart failure. And I've just, as an example of the importance of some of these comorbidities, on the right side of the slide, you can see that if you look at the leading causes of readmission for following a heart failure admission, in the first month, the leading cause of all-cause readmission is psychiatric illness. And the leading cause of heart failure readmission is noncompliance with medical therapy. So you can begin to develop a deeper understanding of why surrounding patients with teams of individuals focused on a holistic approach to care should be advantageous. Many of us have gotten very interested in trying to prevent readmissions through urgent access approaches. And this was an approach that we had developed when I was at Duke, where we developed a same-day access program, where we had a clinician stationed in the heart failure clinic to see people who called in that day and said, I'm breathless, or my weight's gone up by 5 pounds, or my legs are terribly swollen. And it allowed us the flexibility to bring patients in, rapidly evaluate them, provide therapy for them in an outpatient setting, oftentimes by giving them intravenous diuretics. That group also functioned as our triage team. They were highly skilled at some of the remote monitoring that's shown on the right side of the slide. I mean, we've actually moved from scales and blood pressure cuffs to much more complicated, complex, and thoughtful ways to monitor patient deterioration and try to capture it early so that we can avoid hospital admissions. And despite what we all think about how accommodating and lovely it is to be in the hospital, it's much better to be there as a care provider than it is to be there as a patient. And I would be remiss without mentioning the importance of advanced heart failure therapies. We've talked a little bit about the complex medical therapy in the bottom left, but transplantation, mechanical circulatory support, all again surrounding a vulnerable patient. And at the bottom right, I don't think that we should exclude the vital importance of, and Dr. Civitello mentioned this idea of futility, but at the end of the day, the right approach for many of these patients is to provide them a higher level of supportive care through palliative care kinds of approaches. And I mentioned that I was going to briefly touch on the potential economic benefits to a hospital or to a system on developing a comprehensive heart failure program. And I recognize that this data is from 2005. I I tried to find something that was a little more contemporary and was unable, but this was some data that came out of Tufts University in Boston, where they, and this was in an era, by the way, before mechanical circulatory support. So they took a cohort of 100 patients and followed them through 3 years. In the first year, 15 were transplanted, 85 were not. In the second year, the number of transplants went up, and the number of non-transplants went down. You can kind of follow that through in this table. But what I want you to see is the cumulative contribution margin over 3 years of this 100 patients. Over 3 years generated what was projected to be almost $6.7 million. So there actually is money likely in a system to support some of the structure that I defined a little bit earlier. So I'll summarize and conclude this way. The heart failure population is vulnerable and is optimally treated, honestly, by a patient-centered multidisciplinary team. Hospitals and physicians are partners in this, and they are both going to be at risk for their outcomes. The hospital should be prepared to make some investments, and if you really want to do this well, you're going to have to appropriately resource the program. And finally, a well-run program can and should be financially viable. So again, I'd like to thank Dr. Ensley and the team for the kind invitation to speak to you today.